Good afternoon, Suchi.
Good afternoon, ma'am. How are you?
Good afternoon. Good afternoon. I'm fine, dear. और कैसे बाकी सब लोग ज्वाइन हो रहे हैं?
Ma'am, you sent a message.
Yeah, Deepika. Yeah, because I have to travel to Nagpur.
Okay.
For next 4 days, I'm traveling,
Right.
and
Ma'am,
now
they'll just
before
they'll
five,
just yeah, before 5. Okay.
I have to reach to Nagpur. So at
Yes,
least
ma'am.
at 3 I have to start. So
Okay.
because 5 o'clock I have to log in for a different Delhi Gynec Forum webinar. My solo CME course.
I'll
So
just give a ring to Poonam, ma'am, and then I think we can start.
yeah, Poonam madam and
Yeah.
other people, Pazai madam, I think.
Yes, ma'am. I'll just
Deepika,
give her a call. Ma'am, just 2 minutes. Yeah, we'll
yeah,
start.
sure. Hello, Dr. Neha.
Hello,
Hello.
hello, ma'am. Hello, yes, ma'am.
Hello.
Good afternoon, ma'am.
Good afternoon. Good afternoon. Has Megha joined? I can see Dr. Deepika. Good afternoon, Dr. Deepika.
Uh,
Yeah, I think
Deepika ma'am has joined. Megha ma'am, I think, will join in some time, ma'am.
okay. And hello.
Good afternoon, ma'am. Sneha.
Good afternoon. Good afternoon, dear. How are you?
Fine.
Good. So,
Yeah, Poonam ma'am has joined, ma'am.
yeah, I can see that. Madam, namaste. Somebody has logged in for her.
हाँ
No,
नमस्ते।
no.
Madam, namaste,
हाँ
namaste.
नमस्ते, कैसे हो स्नेहा? गुड
बिल्कुल
टू सी यू।
ऐसे हूँ अभी तो So 3 o'clock I'm traveling to Nagpur and 5 o'clock from airport I'm joining that Delhi Gynae Forums program. That is a solo CME for me. And
ओके
then,
ओके,
and then next 3 days I'm just traveling. Uh, I have 3 programs tomorrow in different parts of Mumbai,
ग्रेट।
and then coming back to Nagpur for BirthCon. I'll deliver the talk and rush to Chennai again.
ओ माय गॉड, दिस इज रियली
So
फुल प्रोग्राम, फुल ऑन।
since last 3 years now, last few days, madam.
हाँ, दैट्स सो ट्रू,
I know, but
रियली नीडेड।
yeah, because that is what I always say. If you really want to go ahead on the basis of merit, then it's a top job.
यस एब्सोल्युटली,
Yeah, if you
एब्सोल्युटली।
if you have a shortcut, then that becomes easy.
दैट इज ट्रू।
But fortunately, all over India, it is such a response that Sneha, you don't have to tell us. We will tell for you. We will can.
Absolutely, that's what we have been always saying,
So
that people like you have to be in foxy.
never tell. I mean, it's better late than never. Let me just hope for the best. I
So
can see
Chuchi, are we waiting or?
Madam Sandhya Pazai. Madam, namaskar. Pazai, madam, namaskar. Madam has logged in, I think, but yeah. Hello, doctor. Madam, acha, you are from your device. Sanjeevani, I can see Sanjeevani. Hello. Dr. Sheila.
Hi,
Hi.
ma'am.
Hello.
Hello, ma'am.
Yeah, I think you are logged in on different device also. So I said again, hello. I can see your device also. And okay, so have we included Vardha also? Vardha people?
Yes, yes.
Yes, ma'am.
Arre, then I-
Dr. Shilpa and Dr. Ujjwala are from Varda, ma'am. They are private practice.
Yeah.
Shilpa is the secretary of Sevagram Obs and Gynae Society also. And
Okay.
Ajay ma'am is from the
Pazit
uh,
madam is from our own Yavatmal, no? She had joined Savangi
she
after.
joined,
Yeah.
so she is in the other society,
Yeah.
Savangi Society, Deoli
And
Savangi.
Madam and me have very good terms right from the beginning. Both her daughters have delivered with me.
Okay,
Yeah, both her
wonderful.
daughters, both the deliveries rather. So that's the reason I wanted to, Madam. She has her class 2 to 4, but she said, "For you, Sneha, I will join. Maybe I'll tip in for 2 minutes."
Hmm, good. So, Shuchi, are we waiting? Shuchi?
Who is the admin today? Abhishek. Hello. Who is the admin from Corona?
Yes, ma'am.
Yeah, Abhishek
Ma'am,
or who?
ma'am, we are live now.
Okay, okay. I think Shuchi, we can start then.
Yes, ma'am. Good afternoon, respected chairpersons, moderators, and esteemed panelists. Before we start, let's start on a note of prayer.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
We have gathered here today to have an informative discussion on respectful maternity care organized by DSOGS along with Sevagram. Respectful maternity care is a right of every woman and it ensures well-being of women and their newborns during pregnancy, during labor and delivery. It is also the duty of every obstetrician to see this through. Unfortunately, there are sometimes unforeseeable events that may take place intrapartum as well as postpartum period that may come as a nightmare to the obstetrician team, which may end up hampering the respectful maternity care. Today, we have an interesting panel to discuss how to discuss these problems and how to tackle and manage them. As a chairperson for the first panel discussion, which is a case-based discussion on labor room obstetric events, we have Dr. Poonam Verma ma'am. Dr. Poonam Verma ma'am is a director and professor in and medical superintendent in Kasturba Hospital, Sevagram. She has had an advanced training in SRH Hospital, and she's a committee in FIGO. She's a resource person and expert for Government of India for National Guideline Development in Maternal Health, nodal officer on FBM MDR committee as well. Ma'am has got numerous awards for the management of anemia, special certificates, as well as for her various projects. Ma'am, I kindly request you to introduce our moderator for today, Dr. Sneha ma'am.
So, very good afternoon to all of you. It's my proud privilege to introduce my colleague and a very good friend, Dr. Sneha Bhuiya. Dr. Sneha Bhuiya was a chairperson of Breast Committee FOXY 2019-21, Governing Council member ICOG to 2021 to 2022, AMOX chairperson of Medical Disorder Committee 22 to 24, AMOX chairperson Emergency Obstetric Care 24 to 26, founder president Vidarbha ISOPAR and member of CEFOG Working Group for Breastfeeding. Dr. Sneha Bhuiya is going to stand for FOXY Vice President West Zone, and we all wish you all the best, and I'll request everybody that she's a true candidate for that. She has been a great clinician, a great academician. You can hear her lectures, the way she gives. very thorough as far as her knowledge is concerned. Over to you, Sneha. We are really waiting to see this panel which you have been moderating. Thank you very much.
Thank you so much, madam. In fact, indeed, just having blessings from you and, of course, best wishes from all our dear friends who, because of my busy schedule and, of course, the campaign, I could not meet personally, and I'm just trying to connect with them virtually. So I welcome all of you. I can see Dr. Kiran Borkar joining there, all my dear friends. Hello. So without much ado, I would just initially thank Madam Poonam Verma and Dr. Shruti for taking this initiative. And I would also thank Dr. Deepika and Dr. Megha Karnik, who I think I can't see Megha still join, maybe she's busy. So hello, Dr. Nima Acharya. Thank you so much. And, you've been so busy and traveling, you could join for me, so that I'm very happy for that. And thank you so much once again. Without much ado, I would start with the panel discussion straight away. I would just like to thank Nima also, because just for my request and to support me, she has joined even when she's busy with other activities also. So I welcome all the panelists, and I hope you can see my slides and you can hear me well, right? So, uh, Dr. Neha, can you just inform me whether all the panelists have joined?
Yes, ma'am. Uh,
Yeah,
Ma'am, we've got all the panelists with us now.
right.
I'll Yes, ma'am. I'll just ma'am
If you
introduce them.
can introduce them, that is what I wanted to request you. So please,
Yes, ma'am.
just to say hi to them, please introduce them first, and then I will go ahead with the panel discussion.
Yes, ma'am. We have, ma'am, two other chairpersons also with us, ma'am, Dr. Smita, ma'am, and Dr. Pajay, ma'am. Dr. Smita, ma'am, has been a director of Vatsala Pavre Nursing Home. She has a private practice over the last 20 years, and she has special interest in cervical cancer screening, colposcopy, as well as infertility. She has held many camps of cervical cancer screening as well as various diagnostic camps every month. Dr. Pajay ma'am is a professor in JNMC Vardha. She has a teaching experience of more than 35 years and various publications in national as well as international journals. She is a past secretary in DSOGS. So, ma'am, we have our panelists with us today. We will be starting with Dr. Shrutika, ma'am. Shrutika, ma'am, is an assistant professor with us in Savangi, Vardha. She's specialized in infertility and high risk obstetrics, as well as ultrasonography and hysteroscopy. Dr.
Welcome.
Sheila. Yes, ma'am. Dr. Sheila Shelke, ma'am, she's an associate professor at Sevagram. She was a past president of Sevagram Obstetrics and Gynecological Society in 2022-2023. Ma'am has got numerous awards in academic excellence in 22-23, and she's well known for
Welcome.
laparoscopic surgeries as well as gynec oncology.
Right.
Uh, Mogre ma'am has a consultant obstetrician and gynecology and has a private practice of over more than 20 years in Vardha.
Mhm.
And we have Vanjari ma'am. Yes, ma'am. Vanjari ma'am is she's a professor in the Department of Obstetrics and Gynecology in Sevagram, Vardha. Ma'am's specially interested in infertility, laparoscopy, colposcopy, as well as high risk obstetrics. We
Welcome,
also
Sanjay. Next.
uh, yes, ma'am. We have Shilpa Pandey, ma'am, as she's having her well-known private practice in Cortex Hospital, Vardha. And last but not the least, we have Dr. Deepika, ma'am, who's the current president of DSOGS OBGY Society. She's an associate professor with us at JNMC Vardha, and ma'am has special interest in minimally invasive surgery and preventive oncology, ma'am. So, ma'am, we would like to start our discussion. Our topic is of gaze-based discussions on labor room obstetric emergency scenes.
Right. So thank you so much, and I am very happy to have Madam Poonam Verma, Madam Fazai, and of course Dr. Smita Paude as the experts for this panel. And I welcome all the panelists: Dr. Shrutika, Sheila, Ujjwala, Dr. Sujivini, Shilpa, and Dr. Deepika. So I welcome all of you. So friends, purposefully we have selected this very practical topic. And as all of you know that though I'm an academician, I'm primarily a practicing obstetrician since last 33 years now. Though initially I was in Government Medical College for 5 years. So with this, I would like to discuss these cases in a practical way of management, which is, evidence-based. So friends, you will all agree to me that childbirth is a sentinel event in the life of a woman and her family. I'm sure you must have heard that, मराठीमध्ये आपण म्हणतो की बाळंतपण हा स्त्रीचा दुसरा जन्म आहे. That risky this situation is. So both these intensely emotional as well as intensely physical, and it is not that easy. 1, 2, 3 pushes and the baby is out, as it is shown in maximum movies. The aim of our labor is, of course, having a healthy baby from a healthy mother, and it should be an emotionally fulfilling experience for her. And of course, she expects the respectful maternity care from all of you. As a trainee obstetrician, or even today as an experience of practicing obstetrician, I'm sure we still have the challenges to be faced, especially for the second stage of labor. And whether you are a follower of the watchful expectancy and masterly inactivity, or you're a follower of the appropriate and timely intervention, or what is called as the active management of labor, you will, your way of management will differ. So let us go ahead with few of the cases. Initially, we will cover few of the placental and cord complications, and then we go ahead various emergencies for the malpresentation. So we have this 35-year-old grand multipara. She's delivered at home by the dai. Placenta is also removed at home, and she's brought to the labor room with profuse bleeding. Her vitals are, she's got tachycardia, hypertension, BP is 90/50 only. Provisional diagnosis. Who will take up this case? What is the provisional diagnosis? Dr. Shrutika. What is the provisional diagnosis from the history per se? Dr. Shrutika, do we have Dr. Shrutika here? Yes. Please unmute. Please unmute. Click on the mic icon here. Yeah.
Yes, ma'am.
Now, please go ahead.
So she's, ma'am, a grand multipara, and she was delivered at home. And the placenta might not have been delivered by control for traction and counter pressure.
Placenta is removed at home. So what is the clinical diagnosis? Right.
Ma'am, it seems to be a case of inversion of uterus.
I have not said anywhere. It is only the placenta is removed at home, and she is brought to you with profuse bleeding PV. That's all. And now she is in hypotension. So from this,
and there might be retained bits of placenta that is causing postpartum hemorrhage.
Okay. So your primary diagnosis is postpartum hemorrhage,
postpartum
right?
Hemorrhage.
Yes. And now you have to know the cause. So when you are examining this patient, you find that, already she's got tachycardia, hypertension. And when you palpate per abdominally, you don't feel the uterine fundus. And when you examine locally, she's, it's in the pool of blood, and you see a large fleshy mass. You cannot even do PV. Okay, you cannot locate the cervical ring also to see whether there are any written products. Now, what is your diagnosis, Dr. Shruti?
Ma'am, since the uterus is not felt per abdomen, and on perspicuum examination, we can feel the fleshy mass, which must be uterus inverted inside out. So it is a case of inversion of uterus, ma'am.
Right. So
acute uterine inversion is there, ma'am.
Right. Now you tell me, what must have gone wrong? What may be the causes for this?
Ma'am, since she is a grand multipara, she must have landed. She must have had uterine atony, and if we deliver the placenta without giving counter traction on the fundus while the uterus is atonic, there are high chances of uterine inversion.
Right.
Especially since she is a grand multipara, ma'am.
Right. Right. So basically, it is a mismanaged third stage of labor.
Yes,
usually, that's the cause. But what are the other causes for this? Maybe she's done it, control contraction properly given, but in spite of that, this has happened. So what can be the causes for this?
Ma'am, it can be because of atonic uterus
Right,
and
you're right.
and
Two things, you are holding the uterus, you're pulling the placenta. So either the uterus is atonic or the placenta is adherent, right?
the placenta could be adherent, ma'am. The placenta could be
Fundal
adherent.
placenta with a short cord, that also can
Yes,
be
ma'am.
one reason. And of course,
Yes.
adherent placenta, right? So we will not discuss the theoretical aspect and what degree of inversion she has. All of you know this. If at all there are PGs, they have to know all this. But we clinicians have to manage this case. Okay, so how will you manage this case, Dr. Shrutika?
Ma'am, first of all, I'll try to deposit the uterus, and then I'll give her a uterotonic agent.
Before that, your patient is in shock.
Yes, ma'am. I'll simultaneously resuscitate the patient, uh, and while stabilization, I'll try to deposit the uterus manually to its position, and with the other hand, I will support the fundus of the uterus suprapubically. So that is, I'll first attempt manual reduction.
Yes, no. So how do you do that? What did you say that?
Ma'am, I put my hand in.
All aseptic precautions. So first and foremost, you will stabilize your patient because you
Yes,
will
ma'am.
call for help, and one of your teammates, they will manage her shock, and you will
Yes, ma'am.
prepare for the reposition. So how do you do that?
Ma'am, I try to push the uterus through the cervix, and with the other hand, I'll try to support the uterus suprapubically.
Correct. So
And
actually, we'll start. Anybody else? I would ask Dr. Shilpa to please continue this discussion ahead. Dr. Shilpa?
Yes, ma'am.
Yeah, please go ahead.
So, ma'am, actually, the patient is in shock. So, I will first, it can be due to
that she is covered, that she will stabilize. Now, how will you repose the uterus?
Okay. So, the first maneuver we can do is Johnson maneuver. That is, we have to put our whole hand with almost half of forearm inside the uterus, and we should give bolus IV pitocin.
The uterus is inside out; it is inverted.
So we have to put the fist inside the vagina with almost half of forearm and try to reposit the uterus inside the abdominal cavity.
Yeah, so that is what I am asking. How do you start reposing? Okay, because
we should the part which has ma'am. The part which has we can see actually we should go from lateral to middle. Lateral to medially we should go, and then we can reposit it.
Right. So the part which has come last, okay?
Last.
You will not repose this first. You will repose this first, correct? So it's the part which comes last, that is the near the cervical rim, that you will try to push in. So slowly the body of the uterus and then the fundus of the uterus goes in like this, right? Now, when your hand can go inside, you will keep your hand, and of course you will ask your assistant or your team to give uterotonics. Okay. Yes. Should we keep this hand for some more time, and how much time? And then for how long we should give the oxytocin?
I think we should be sure that uterus is well contracted. Up to that time, that can be about 10 to 15 minutes. And then we can we should run the IV fluid with pitocin and watch the uterus that it is contracted. And then we can remove our hand.
So that period, how much period? I would say post procedure.
I think it should be 10 to 15 minutes.
Yeah, but then how long you should continue the oxytocin infusion?
For 2 hours.
It has a tendency to again have a recurrent inversion, right? So at least for 10 to 12 hours, you should continue the oxytocin infusion. That is all, right? You have to make sure that it remains contracted. It doesn't recur. Okay. So that is how you have to manage this. Now, suppose your reposition manually doesn't help. Then what are the other ways? I think we will go little quickly. This is not a very common condition, but you have to know if at all it happens, how do you manage it?
I think we can use vacuum cup with like hydrostatic measure. We can insert that vacuum cup and attach the tubing to
From
it.
where?
Can
From
instill
where?
2 to 3 liter of warm saline
Uh-huh.
and just put that saline bottle 1 meter above, like it should be like a higher position from the uterus, so
Right.
that warm saline could be instilled, and with that pressure uterus can be reposited. That
Correct.
can be another method.
Correct, correct. So, Dr. Ujjwala, can you tell me that suppose, manual reposition also didn't help, the hydrostatic pressure also didn't help. Now what will you do?
Now we'll go for removing the constriction ring, the cervix which is there besides which it is not allowing the uterus to go inside.
So,
If it is not able,
vaginally or abdominally?
Two processes, madam. We can do vaginally also, and we can do abdominally also. Vaginally, we can go by two methods. One is by cutting the anterior ring of the cervix, and the second is by posterior ring.
Right.
And after that, we can reposit it. And there is one more method where we can open the abdomen and then cut the posterior part of the ring and then reposit the uterus. And
right.
After that also, if the bleeding is still there and uterus
so
is
whether you
very much
directly cut the uterine constriction ring, or you can have simple measures before that.
You can stretch the ring first. You can
Yeah.
try stretching the ring, and then if it is easily possible to reposit it after stretching the ring, then we don't go for any surgical procedure. But firstly,
we
we
have
should
already
try by
opened the abdomen, right? We have already opened the abdomen. But, so
Yeah.
you're right that you have to pack the bowels, and you have to just try and hold the uterus like this at the lowest point, and you try and flip your fingers anteroposteriorly, so that slowly the fundus comes up like this. You can see the dimple here. Okay. Both your hands will work simultaneously. Otherwise, if that doesn't work, then of course you have this what is called as the Huntington's procedure. That means slowly you apply a non-traumatic instrument from both sides, and slowly go on catching, advancing, so that you can pull the fundus up. That is one. Suppose if this doesn't happen, then you have your manual stretching of the cervical ring, and then of course what you described very rightly, that you cut this ring, you deliver or push the uterus above, and then you suture it back to normal, back to its original. So very nicely discussed. And this is what your vacuum cup, which you can apply abdominally, because outside though it is inside out. So you will not, in fact, you will need something to push and not to pull. So abdominally, definitely you can apply this vacuum cup to pull the fundus up like this. So because now why you have to know, because things have gone wrong previously. People have could not recognize it, could not manage it in time. It has resulted into gangrene of the uterus and resulted into obstetric hysterectomy. So that is why we have to know it. I'm sure vaginal deliveries nowadays, you are not facing these problems much more, because all of you are trained so well, all of you are experienced, what is Brand Andrews method and the control cord traction, how to apply. But even the PGs, they should learn at this point of time only, that you must give adequate time to wait for the separation or the signs of separation of the placenta. You should know, then only you should give gentle traction and counter traction simultaneously to avoid this complication. So I'm sure, though not for vaginal delivery, you must have experienced this even at cesarean section. Correct? You pull the placenta, you feel the entire uterus is coming out, then you stop and wait for separation, right? So let us be honest. And this is what is the oxytocin, what I was talking about, that you have to continue it 8 to 12 hours. After, of course, what oxytocin to be used, you have to know everybody. So now we go ahead. I think Ujjwala only has discussed this case. So we go ahead with the second case. Again, we start. I hope I have not missed any of the panelists. Sanjeevani, Dr. Sanjeevani, we start from you. We have this.
Yes, ma'am.
37 weeks, primary gravitas. She comes to you only in early labor. When you examine, you find the vitals are normal. The contractions are only 25 seconds mild every 4 to 5 minutes. But the head is floating. Fetal heart is good. So you are relaxed that, the patient is in early labor. But you are relaxed, but you're monitoring the patient. So when you monitor her fetal heart, suddenly you find that it was normal 10-15 minutes back, but now it is a sudden drop. Okay. So what is your diagnosis and what can be the cause of this sudden drop in fetal heart?
There can be several reasons for this. First thing, we should think that there may be a cord around the neck which is getting tightened, or we should do the per vaginal and per speculum examination to see whether there is any breakage of liquor amni, rupture of membranes has occurred. And because with a floating head, there is a possibility that cord will prolapse with spontaneous rupture of membranes. And
the second possibility is more likely the cord prolapse, as you have said, because the head is floating and the membranes have ruptured. About the first possibility, you said cord around neck, it will not have sudden drop in fetal heart because she's not neither having strong contractions, she's not having even the descent, right?
Yeah, correct, ma'am.
Usually it happens when the baby is descending down and there is tightening of the cord, right? So definitely the cord prolapse is your diagnosis. So madam, how will you go ahead with the management of this patient?
Madam, because if it is a cord prolapse, then we have to immediately shift her for a cesarean section. And in the meantime, we have to repose the cord inside. The person who has done the PV should not remove the hand. She should keep the hand there and there. And with the hand there and with packing around it also, if it is possible, the aim should be that the outside air should not touch the cord, otherwise the cord goes into spasm and the blood supply is cut off. So in that same position, immediate shifting to OT and swift delivery of the baby is the
So I'm sure even if you are so prompt, at least the anesthetist, neonatologist, they will take some time to reach to your hospital. Maybe I would say at least 15 to 20 minutes for a smaller cities and more than half an hour for a big, larger city, right? So meanwhile, how do you manage this patient?
We should
don't remove the hand, you keep the cord inside. Agreed. Anything else?
We can give her a head down position, give her oxygen inhalation, IV fluids, and see that the oxygenation to the baby continues.
Right. And of course, what is described as the knee chest position supposed to be the best to avoid the cord compression further by the presenting part, right? So that is how it has been described, that you have to deliver the baby at the earliest by whatever mode. Suppose if she is almost fully dilated, you find she's multi and she'll deliver soon, even before the anesthetist comes, well and good, you deliver her by instrumentation. But your primary aim should be to deliver the baby at the earliest. Suppose, Dr. Sanjeevani, if you do her per speculum examination, you find that there is rupture of membranes, but you feel for the cord, so there is no cord prolapse. You don't feel the cord. Then what is it?
Then it can be that if the membranes are intact.
Membranes are ruptured. Membranes are ruptured. You are in the same discussion. Only I'm giving you little tricky situation of the same diagnosis. I can again give you a clip.
And head is floating.
Yeah.
It can be occult cord prolapse.
Yes, perfect. So because you are trying to feel for the cord, things are same. Same patient, same condition, same happening, that rupture of membranes. But the cord, instead of coming down below the presenting part and you can feel, it is just descended down on the side of the fetal presenting part, okay? So here you can't feel the cord, but side somewhere it is getting compressed between the myometrium or the uterine wall and the presenting part, okay? So that is what is also, it has descended, but not exactly prolapse outside the os. So that is what is called as the occult cord prolapse. And of course, there is one more condition, what is called as punic presentation. That means which is not related to this patient. So suppose, now what must have been missed for this patient, that when you do ultrasonography, suppose you are doing ultrasonography, you find the baby's head is floating, head or maybe the other presentation floating, maybe even transverse lie, breech or so, but you find the membranes are intact and you find the cord before the presenting part. So what is that?
That is a cord presentation where we can diagnose it with even through the intact membranes by feeling the pulsation we can feel over there.
Correct. So one
In
is ultrasound and second is internal examination. You can feel the pulsations even when the membranes are intact. So that is Punic presentation or cord presentation. Now suppose this patient you have diagnosed it earlier, then what you could have done? Before rupture of membranes, suppose you find that your patient has Punic presentation, then how would have you manage this patient?
It is better to go in for a cesarean because in any event the membranes ruptures, then you are going to have a cord prolapse.
Right. So I would not say it is better to go. It is recommended even by RCOG that you pick up the diagnosis at the earliest. You do what is called as, how do you do admission test for NST? You should do admission ultrasound to labor room. And if at all you find that there is a Punic presentation, you don't allow this patient to go into even active labor and you go up for elective cesarean section, because the moment she goes into labor or she ruptures a membrane, it's going to be the frank cord prolapse, right? So artificial rupture of membranes, manual rotation of fetal head when the head is not well fixed, these are the aggravating factors, and in such conditions we should try and avoid these actions. So the management of principles of management of labor you have already talked about. These are the RCOG guidelines which say that, you know, even though the incidence of cord prolapse is less, the clinician should be aware of all these, you know, several clinical factors, because these are the cases which come from clinical case discussions. And I have witnessed myself one case at Sassoon General Hospital when I was a resident, and that chief resident was fired and, you know, detained from this. The media has taken it very high. So, you know, things can go wrong, because once you diagnose the floating head or malpresentations or the Punic presentation, you must go ahead with the cesarean section. If at all as an emergency you diagnose cord prolapse, you must go for the emergency cesarean section at the earliest. That is what all these recommendations are, that it should be diagnosed and identified early, early detection of cord presentation and prompt treatment by operative cesarean delivery. So with this, we conclude the second case now. And now, do we have Dr. Deepika, the president of Devis House?
Yes, ma'am.
Hello, Dr. Deepika.
Good afternoon.
Good afternoon, dear. So this is a discussion for you. We have this, fourth gravida with a 28-year-old lady. Previous 3 abortions she had. 39 weeks pregnancy. Now she comes in labor, delivers a full-term baby girl. Placenta is not expelled for almost 45 minutes, even after birth of the baby. So what is your diagnosis, Dr. Deepika, and how will you go ahead with the management?
Ma'am, I keep 2 diagnoses in my mind. Number 1, that she could have adherent placenta.
Yeah, but you said 2 diagnoses. You said 2 diagnoses.
Yes, ma'am. Number 1 could be adherent placenta because of previous histories of 3 abortions.
Right.
And another could be retained placenta in view of atonicity of the uterus.
Right. So you are right in a way, but little correction. I would say there will be a single diagnosis at this point of time, that it is a retained placenta. Now we have to evaluate to see whether it is a simple separated and retained placenta, or whether it is a just adherent placenta which you can remove with MRP, or whether it is a adherent morbidly adherent placenta. So now how will you go ahead with the management of this patient?
Ma'am, I would shift her to OT first of all, and I would make arrangements of blood transfusion and inform the anesthetist, and would prefer to take the patient under GA.
Okay.
And
anybody else differs from this, or maybe wants to add something, whether you will directly take her for...
Madam, we'll try to remove the placenta without anesthesia first, by going through the cleavage, by putting a hand inside the uterus and searching for the plane.
Yes. Okay.
Actually, we should...
whether if you do like this, and if she bleeds torrentially, or if it is morbidly adherent, you just heard that it will lead to uterine inversion maybe, right?
Or you can try oxytocin injections in the umbilical vein, and then we can wait for some time for its expulsion.
Okay, okay. Anybody else wants to add anything? Simple measures. 2 steps, I think, still we are missing. First and foremost, I'm sure all of you are clinician, practicing dietitian. You know, sometimes if the patient has a full bladder, the uterus just relaxes, right? Have you experienced it? So first and foremost, catheterization or emptying the bladder, that itself can give you good tone of the uterus. Okay, that is one. Maybe you just start with 20 units of oxytocin infusion. That is two. And thirdly, as Dr. Deepika said, it can be a morbidly adherent placenta. Don't directly go for removal of. Nowadays, it is not allowed. All of us, you and me have done. Even I have done this 35 years back. Maybe even up to 20 years back, I have done this. But nowadays, when the patient is not bleeding, stable, why do you want to disturb her? Right? So you have a time. So what will you do? What investigations? Now back to Deepika. What investigations to rule out the adherent placenta? Very clear.
Feasible would be ultrasound only, bedside.
Right, right. Why not? Why not bedside? We can shift the patient even to the department also, right? If you have bedside ultrasound, very well. Okay. So first and foremost, what will you look for?
From the vascularity. Number one, the vascularity, and number two, the depth of invasion, the location of placenta.
First and foremost, you will confirm whether it is really adherent or there is a plane of cleavage, right? Sometimes you feel clinically it is not, it is not getting separated. But when you do ultrasound, you find a very clear retroplacental membrane. Yes. So if that is maintained, then there is no problem. You can take her for MRP. But if you feel adherent placenta, then what are all the features you look for? One is excessive vascularity.
Ma'am, presence of any abnormal vascular lakes on ultrasound would be suggestive of a morbidly adherent placenta.
And absence of that retroplacental sonolucent zone, you find that laminae entering into the myometrium, right?
Yes,
so these are all the features which you can see even with a good resolution ultrasound and experienced sonologist, you can diagnose morbidly adherent placenta to the tune of 100% almost. There is even no role of MRI. Let me clarify. According to evidence also, and practically there is no role of MRI unless you have a morbidly obese lady or a very deep posterior placenta, or when you are trying to plan for some conservative procedure for the uterus, when she has, triple P procedure, knowing the depth of invasion. Correct. So now you tell me that suppose your patient has a simple adherent placenta. So we continue with Dr. Ujjwala. Now what will he do now?
Madam, we will try to give her IV fluids, give her oxygen, then empty her bladder, catheterize her, then call for give the anesthesia, and under anesthesia, and we should stop the uterotonic so that the uterus is relaxed and we can enter our hand inside. We can put our hand inside, and then we go for the cleavage in between the placenta and the uterus, and then we try to remove the placenta slowly. And then you can take the cotyledons in your hand, and then you can remove it properly. And then if there are any pieces left,
should we remove piecemeal or should we remove as a whole?
Madam, if you get the plane properly, we can remove it as a go. But if it is possible that it might be mildly adherent, and there might be some pieces of cotyledons which are left inside.
Simple adherence, yes.
Yeah. So we can then do a suction or then remove it by hand.
Okay. So you have removed the placenta. Now what do you do?
Then we give a uterotonic immediately because so that the uterus contracts, and then we look for any bleeding, and
what
we
do
watch
you
her.
do with the placenta which you have removed?
We see if all the parts of the placenta have been delivered, like all the cotyledons, and then along with the membranes are delivered completely.
Right.
And then
should we inspect the maternal aspect or the fetal aspect, and what information do you get because of that? When you say that if at all something is, some cotyledon is missing, you will try and search for it. the fetal aspect membranes. If at all you have a succenturate lobe of placenta, the part continues from there. So you get the idea that yes, there is a succenturate lobe. We can remove that. Okay. So even after you have removed the entire placenta, you will again explore the uterine cavity and look for whether anything is remained, maybe some pieces or membranes, right? Then you will give antibiotics. And how long do you continue the oxytocin? Once again, I ask you the question.
Again for 10 to 12 hours, madam.
Yes, you must continue this, correct? So that is very well discussed, Dr. Deepika. Now we come back to Dr. Shruti. I think we take Dr. Sanjeevani also. Yeah, Dr. Sanjeevani and Dr. Shruti. Dr. Shruti, we start with you and then we take the discussion ahead. We have this second graduate, one. She has one previous normal vaginal delivery. And at 36 weeks now, she comes to you with strong labor pains. Her vitals are normal, fetal heart is good. You find, because she's got strong pains and she's pushing. So you just go for PV. You find the cervix is fully dilated, fully effaced, and breech presentation at +1 station. Now what do you do? Pelvis is adequate. Now how do you manage with this patient?
Ma'am, since she's 36 weeks with history of previous vaginal delivery, and she's in labor, station is at +1. So I can conduct a vaginal breech delivery in this patient.
But suppose she doesn't deliver, and how do you decide that? She comes to you.
So ma'am, there is a scoring system called ZA scoring, Zatushna Andro scoring, which takes into account various factors like the gestational age, previous vaginal deliveries, previous breech deliveries, and cervical dilatation, station, and if the score is between, yes ma'am, and the estimated birth weight also, and if the score is favorable, then we can give her a trial of vaginal breech delivery, and if the score is poor, like less than 4, then we do a cesarean section in that case.
Right, you said trial, but now she's already in second stage, right? So you have to, by the time, the patient will say, you are a doctor, you decide what do you have to do. Then even when she's had one vaginal delivery, is it that 100% she will deliver safely or how? Dr. Sanjeevani.
Madam, because she is 36 weeks only and previous NVD, previous vaginal delivery is said to be a good indicator of the adequacy of the pelvis.
Agreed with Shruti and you, both of you.
Yes.
But suppose she, she pushes, the baby comes out and the head gets trapped. And then there are some complications. Then who is responsible for that? The patient will say, I have told you, doctor, you take your own decision.
Yes, so we can counsel the patient that she has two options.
That should be the first step, right?
Yes.
That should be. So, all of us have to see, I'm from your side, right? So all of us have to see our safety first and the patient safety as well, correct? But then you have to counsel the patient right at the first instance. See, that was a normal vaginal delivery. When it was normal means it was head, and this is breech, so there is something abnormal. Okay, so we have to tell that even if you have delivered vaginally then, and maybe you will deliver vaginally now also, but there is a problem because it's an abnormal presentation, right? And then with informed counseling and what is called as shared decision making, that means you tell her the advantages, disadvantages, whatever she agrees, you write it down. So informed written consent for either the vaginal delivery or the cesarean. If she says, no, doctor, I don't want any risk, please you decide first. So that is the best time where you can go for cesarean section. Don't insist the patient for vaginal delivery. Maybe by the time you arrange for cesarean section, if she really delivers, that is a very happy moment for everybody, right? But now suppose she just pushes the buttocks, so how would you deliver her?
Actually, we should just do least amount of intervention till the buttocks present at the perineum.
Yeah, buttocks have presented to you at the perineum. Now how
then now we should give a liberal episiotomy first, and then let the first find out what is the type of breach. If it is a frank breach, then she will require assistance at the time of delivery of the legs also. But if it is a complete breach, the legs should come out very easily, and then the baby should deliver up to the umbilicus. Once up to the umbilicus the baby has delivered, you can take a loop of the cord and feel the pulsation, so that it can give you a indication about how much time you have, because there should not be very much haste during the delivery. Otherwise the head will become extended. So then again you hold the
so let the patient push continuously.
Yes, and we can start oxytocin drip also if it is not there already. Cover the baby with the help of a towel, and then just allow her to deliver up to the just below the shoulders. Then she will require assistance for delivery of the shoulders.
Correct. So how do you deliver the shoulders? I would just interfere. Sorry, Sanjeevani, I would ask you, suppose, you said she is a frank breech. The legs are like this here. Now, how do you deliver the legs? Because you have the PGs also joined here, no? So let us discuss. Yeah.
We have a special maneuver, that is the Pinard's maneuver, which we can do. What we do is we insert our hands over the ventral aspect and go up to the popliteal fossa of the limbs, and you just depress the popliteal fossa so that the legs become flexed and abducted, and then catch hold of the foot and bring it down. First you bring one foot down and then the other foot down.
Yeah, right. Ask your patient to push continuously, and you don't you have to just make sure that the back is anteriorly. Don't pull. Okay.
Yes.
What else? Now that the baby is delivered up to nape of neck, now you have to deliver the shoulders, right?
Yes. So for shoulders, we have to, because the posterior or the sacral curve is the most roomy part, we can just turn the baby to through 180 degrees, so that we get one of the shoulders posteriorly, and just put your hand inside along the sacral curve and hook out the hand. Then you sometimes you just depress the baby and you can get the anterior shoulder out as well. Suppose you have difficulty in delivery of the shoulders, then you have to again rotate the baby through 180 circle, get the anterior shoulder to the posterior, and then catch hold of the hand and then deliver. So delivery of shoulders can be slightly tricky in this situation.
Right. Now you have delivered both the shoulders, Dr. Sanjay. No, but the head is not coming out on its own.
That is with the head you have to be most careful, otherwise she will can have neurological sequelae also. So allow the baby to hang, it is said, by the neck. So that is
by its own weight, right?
By its own weight, and not by its own weight actually. You should support with your one hand. One hand is on the ventral aspect of the baby and other is on the dorsal. With the underlying hand, you support the baby. Other hand, you keep on the shoulders of the baby. And then the head has to be borne by the process of extension. For that, you have these various techniques. Most commonly used technique is the Burns Marshall technique, where you catch hold of the foot of the baby, and then you turn the baby, which was hanging down. You bring it anteriorly like this, and then upwards, so that the baby's feet reach the abdomen of the woman. In such a way, what happens? The head is borne by the process of extension, with the other hand supporting the head adequately.
Right. The left hand should, keep continuously supporting the head. Right. Okay. And suppose if this doesn't work, Burns Marshall, then what maneuvers you have?
Then we have the second, that is the Marisol Smelly Wheat technique, which goes by the three persons who have invented this technique. In this, what is done is one finger, that is the middle finger, you hook it inside the jaw of the fetus, and the other two fingers,
do you recommend it to hook, or maybe just keep below the chin?
We can just give a support also on the chin sometimes, but if we hook it, it becomes we are more confident of causing flexion and delivering her.
Yes,
so the other will be
But maybe, sometimes people have, landed up into TM joint dislocation, this, that. So that's a very reason I think we just support the chin. If at all needed, yes, of course, you have to put inside and hook it down. Correct. And what about the right hand?
Right hand has to be on the shoulders, and this all is taking place at the level of the nape of the neck.
Correct.
And with the two hands, again the same technique, you have to bring the head out by extension. So again the movement will be forwards and upwards towards the maternal abdomen, and the head will be borne by extension with
Right.
proper support.
Yeah, so this is actually what is called a jaw flexion, what you describe with the left hand. You put a hook in your hand in the jaw, so jaw flexion and the shoulder traction. So these three
Yes.
fingers, one is middle in the occiput to further help the flexion, and two fingers on the shoulders to give little traction on the shoulders. Right, very nice. So I think we can have Dr. Who else is there? Sheila? Dr. Sheila? Yeah. Please guide us on the this forceps, if at all you have applied sometime. I would request you to stop the other device. You have to, I think, log out or maybe mute it. Yeah. Hello, Sheila?
We can use Piper's forceps. Piper's forceps is used for after coming head of the baby in case of breech delivery. Before that, you have to judge it clinically. We have to apply the Piper's is used because it doesn't have pelvic curve. So it is applied easily. It can go beyond the head, and both the blades can be locked easily if we use Piper's forceps.
Correct. You're right.
And then baby's head can be extracted. Along with that, you have to give suprapubic pressure just while taking it out, so that there will not be any difficulty.
Yes. So once the baby is delivered,
you should always take written informed consent.
Right. That have to, in fact, what we discussed initially, counseling is very important. Even for vaginal delivery, we have to tell them it can be a difficult delivery, it can be an instrumental delivery, and there can be all these complications, right? So very well discussed case. All of you have, discussed all the maneuvers that is required for what is called as assisted breech vaginal delivery. So thank you so much.
I want to add up.
Please.
That is alternate birthing position. Nowadays we are practicing in sonogram. All four position is the best position to deliver a breech.
Yeah.
And it will help in smooth delivery of the breech.
Which position you said? Knee chest.
Hello.
Which position you said?
All fours position, ma'am.
Okay, all fours.
Because that will increase the diameter. So there will be smooth delivery, and there will not be any problem in taking out after coming head also. That's what we have found out.
Right. That is what has been propagated all over world. Even the FIGO precipitator is delivering that. That is what I said, what is called as knee chest position.
Yeah.
Okay. So now we quickly go ahead with this last case now. And Sheila, I think you only have to take this case. We have this 34-year-old second gravida. She's got JDM, and at 37 weeks, she comes to you in labor. All these findings are like a routine patient. You have, she progresses very well. Now she becomes fully dilated, fully effaced vertex. You can see at perineum. But after almost 20 minutes of full dilatation, you can see the head coming out. You're very happy, but suddenly the head withdraws, retracts once again. What is it, and how do you?
That is shoulder dystocia.
Correct. Yes.
Turtle sign, we can say it as a turtle sign. And for the delivery of shoulder dystocia, corkscrew maneuver is the one which we do. And if that is not, nowadays we can just put a patient in a different position, all fours position. In that also it will be very smooth delivery. Rather than going for maneuvers first, we can change the position if possible and try first that thing.
I would say, Sheila, you are so experienced, but one message I want to give you here for these PGs also and the new
Yeah.
practicing obstetrician, that even if it is a shoulder distortion, don't panic. Don't
Yeah,
panic.
that is
Just
true, ma'am.
relax
Don't
also.
panic.
Because
That I should
these
have told.
people will feel, oh my God, the baby's baby atka hai. If this baby dies, what will happen? All those things. So, what is your message and what is helper maneuver
Do
and
not
how?
panic. Call for help.
Mhm.
Flex the woman's limb near her abdomen, so that in this same position she can be delivered. First, try
Right.
out that thing.
Ah.
Otherwise, you can just go for corkscrew maneuver, and
Mhm. I think this
suprapubic
simpler one,
pressure is the one.
simpler one, you give hyperflexion of the thighs,
Yeah,
right?
that's what I
Yeah.
told, ma'am. Near the abdomen, you have to flex till the limbs, knees touch the chest of woman.
Right. Hyperflexion and of course the suprapubic pressure.
Yeah.
Okay. So for others' knowledge, I would just ask you this assistant is giving very nicely. It is hyperflexion of the thighs on the abdomen and abduction of the legs. That is giving you lots of space in the pelvis. It is straightening the pelvic birth passage, and also it is increasing the AP diameter. Correct? I
Yes.
would just ask you that if you are teaching somebody where to give the suprapubic pressure, right side, left side, where? How do you decide that? This is very, you can see the head is lying outside. So you can easily make out where the occiput is. Here in this case, it is seen on left side. So your assistant should give the suprapubic pressure on the left side.
Left
Okay.
side.
Left side is the anterior shoulder, which is stuck up there. Okay. And you can see here, because she's giving suprapubic pressure on the left shoulder, that is the anterior shoulder. So, she's pushing it on the chest so that this acromial diameter is getting lesser. Correct?
Yes, sir.
And if this doesn't help, then what will you do?
Reverse
What
corkscrew maneuver. In that, you will hold the head of baby at temporal region, and you will try to rotate by 180 degree. So that
Right.
anterior shoulder will become posterior, and it will get released. And then again you rotate. Same way, posterior shoulder will posterior shoulder will come now again in posterior side. That is longer distance which we have, and then it will get released. By this, both the shoulders are released.
Any message you want to give this people who are delivering shoulder dystocia case?
While doing this maneuver, fundal pressure should be applied.
Yeah.
By your assistant.
Actually, fundal pressure should never be given, Sheila. It is the suprapubic pressure.
Sorry, ma'am. Sorry. Suprapubic.
Fundal pressure should never be given, and there should be no attempt at traction from below. Right? Let it deliver on its own. Let the lady push. You don't pull. Right? So, and no fundal pressure. It should be suprapubic pressure. So, with this, now I invite my experts to make few comments, whatever we have discussed till now. Madam, we are very happy to have your comments. Madam Poonam Verma, do we have, madam?
Yes, ma'am, we have Pajay, ma'am. Sunday Pajay, ma'am.
Madam Pajay, madam.
Yes, ma'am.
Very nice, informative lecture. You have given nice guidelines how to handle the emergencies. Thank you so much.
Thank you, madam. And of course, I'm very happy.
Really,
Sneha,
what a wonderful cases. Sorry, wonderful cases, very practical discussion. I think this was the need of the hour. Thank you very much, Sneha.
Thank you so much. Pajay, madam, nice to see you after a long time, virtually though. And of course, I need your wholehearted support and your blessings also for my candidature as Vice President.
Ram, the whole of Vardha is with you, and it was certainly a very interesting panel discussion. And real good cases and practical cases were discussed, and I'm sure all of us have learned a lot.
Thank you so much. Do we have Dr. Neema?
Yeah, thank you so much, Buyar ma'am, and I'm really apologize first of all for not being in communication for some time. And the thing is, it was really good, specifically for our postgraduates, and I hope they have all watched it, and I think it's there on YouTube also. So thank you so much for the entire this thing. I was listening. I was in OT right now, but all the cases were
Thank you
really
so much.
good. Obstetrics, and we all are always there. You have been always there for us, and we always are there for you.
Thank you.
And best wishes for your vice presidentship elections. Thank you, ma'am.
Thank you so much, dear. Thank you so much for being so nice and support you always. Thank you, dear. Thank you so much. And I'm so sorry. My apologies. I have to leave for the airport. So I have to leave. Meanwhile, on the way in the car, I will definitely join and listen to all of you. Thank you so much, Shuchi, Madam Poonam
Thank you,
Verma,
ma'am.
Deepika, and Megha Karnik. Thank you so much. Thank you, dear.
Best of luck, ma'am. Yeah.
Thank you, ma'am.
Thank you, dear. Thank you so much. Thank you. I just stop share and I will join from the car. Okay. Thank you
Yes,
so
ma'am.
much.
Thank you so much, ma'am. Moving on to our next session, we have a lecture on respectful maternity care and midwifery in India. For that, we have our two respected chairpersons, Dr. Kiran Borkar ma'am and Dr. Manisha ma'am. Dr. Kiran Borkar ma'am is a renowned obstetrics and gynecological consultant at Vardha. Ma'am is also an associate professor at JNMC Vardha. She has been a vice president of IMA Vardha for 1 year, as well as president IMA Vardha for 3 years. Manisha ma'am, she is presently working in District Hospital Vardha. She has served in several rural populations for around 6 years and providing safe abortion services. And she has been felicitated as the best lady medical officer for the district in 2015. I request Kiran ma'am to introduce our next speaker, Dr. Suchi Jain ma'am.
Good afternoon, everybody. Welcome to this second session of today's CME. We all know that the importance of maternity care. It is an example of the preventive health care at its best. It is effective in lowering maternal morbidity and mortality, and we can predict the complication at the earliest, and we can treat it. Also, it helps in improving the perinatal outcome also. Ideally, it should begin before conception and it should extend throughout pregnancy until delivery. So our speaker is going to speak about the details on this factor. Now regarding the midwifery in India, I think it is not very popular concept in our country. But in countries like UK or US, this maximum load is given to the midwives. Also in certain cities of India, like in Hyderabad, I have seen in Fernandez Hospital, Hyderabad, this midwifery concept is there, where all the low risk patients, they are under the midwives. So they are registered under the midwives, and when the patient comes with labor pains, the midwives are there. Then they take the patient, they deliver the patient. Only the obstetrician is standing as a standby. Only the high risk cases, or if they land up in this midwife land up in any complication, then only the obstetrician interferes, otherwise not. So this concept, I think it's not much, will not be any popular thing in our country, because our patients want that our doctor who is treating us for the 9 months, he or she should deliver the patient. So what is the scenario? Let us hear from our speaker, Dr. Suchi Jain madam. About the madam, actually she doesn't need any introduction, but as a formality, I will introduce her. She is an MBBS and MD Gynae. She's PGDGM. I think it is, madam, postgraduate diploma in geriatric medicine. Then FICOG, that is Fellow of College of Obstetric and Gynecology, Indian College of Obstetric Gynecology. MIAG, Master of Science in International Affairs and Global Enterprise.
Ma'am, it's okay.
If it is incorrect, you can correct me.
No, ma'am, it's fine. I think
global.
everybody knows me in Vardha.
Yes,
So, if you permit, ma'am, I'll start with the talk. Let's not waste time.
Okay, she's professor and HOD, obstetric and gynecology at MJMS. Collaborated with various associates like NQO, CIN, Lakshya, ICMR, WHO, CRO, NIH, USA. She's PG teacher and examiner in MUHS and DNB. To her credit, there are various awards like late Dr. Praveen Mehta Fellowship in Endoscopy and Mobicol Corion Award in Senior Category 2023. To her credit, there are various publications, national and international index journal, total 50, contributed in WHO Manual for Cervical Cancer Screening, contributed to Books of Family Medicine. Special interests are high risk obstetric and oncology. Now I invite madam to deliver your lecture.
Thank you, ma'am. Okay, so very good afternoon to everybody. So me and Poonam ma'am actually decided on this topic because midwifery is something which we are doing since last 2 years, and we want to know that all the residents of Wardha that what was our experience and how good it was. And so that is why ma'am was busy with some personal work, so she asked me to present it. However, madam and Dr. Garg sir are the ones who are behind midwifery in Sevagram, Wardha, Maharashtra. So why was this concept of midwifery came up? Because the MMR in India in 2016-18 was 113, which reduced to 103 in 17-19. So 800 women die every day from preventable causes related to pregnancy and childbirth. One maternal death every 2 minutes. However, most deaths are preventable. So WHO find out that midwifery care could prevent 82% of deaths, and quality midwifery education and care improves over 50 health-related outcomes. So the midwifery-led care has a profound impact on outcome and women experience. Women who receive models of midwife-led continuity of care are 7 times more likely to be attended at birth by a known midwife. 16% are less likely to lose their baby. 19% are less likely to lose their baby before 24 weeks. 15% are less likely to have regional anesthesia. 24% are less likely to experience preterm birth, and 16% are less likely to have an episiotomy. So this is women attended by birth by a known midwife reported higher ratings of maternal satisfaction because of information, advice, explanation, the place of birth, preparation for labor and birth, choice for pain relief, and a feeling of well-being amongst them. So that is how it leads to a better experience. Now, how and when this started in India, it was a landmark decision by Government of India in 2018, and it created a roadmap of midwifery services in India, and a new cadre of health workers or the nurse practitioner midwives were created, who demonstrated evidence-based clinical practices and respectful maternity and newborn care, and they demonstrate values needed to change poor historical birth practice. So the concept that midwife is like a dai and we are going back to the dai thing in our country is not that. They are trained nurse midwife practitioners who are actually trained how to conduct a delivery, and they are better, like whatever experience we had is they are better than our postgraduates and us also. So the introduction of this new cadre in India came into the existing health system by training nurses to be midwives and preparing midwife educators in line with the international standards and with midwifery services to meet the global standards. So with this, we had 3 midwives from UK who through the Government of India were sent to us, and these were the international midwifery educators who made the national midwifery educators. And at present, the national midwifery educators at our institute are training the state midwifery educators, and the learners from all across India are coming to us. So these are the birthing positions which we are talking about, the hydrolabor, the hydrotherapy, the way the things have changed, and we have carried out to the international and national standards. So this was the first batch of training which came to our institute, and Dr. Poonam was instrumental in initiating it and bringing it to its present shape. So different organizations were awarded contracts for 16 NMTIs across India. 4 of them were given by Jepaico, and Wardha was a part of it. So this was the first photo when they joined us, and we welcomed them in our department. So this is midwife NMTI Sevagram with the international midwifery educators. So what are the things they stress upon? It is all a part of respectful maternity care. So always consent, respect, and dignity should be there for laboring women. Consent prior to any procedure should be taken. Maintain the dignity and privacy for the women. Have a eye contact. Do a careful, watchful waiting for the progress of labor. ensure clear and contemporaneous documentation, utilize the birth companion. We have 100% birth companion in our labor room. So each woman is accompanied with a female, and sometimes if she chooses a male companion also, that helps her in maintaining hydration, nutrition. She helps her with bladder care, reassurance, giving her massage, the feeling that someone with whom she's comfortable is around her, gives very positive signs. And suppose there are any danger signs, she can report to the healthcare provider that, ma'am, my patient requires attention. So we see midwives as professional decision makers, and we work in collaboration with them. At present, they are managing the low-risk labor room in our hospital, and clear guidelines are there as to which patient they can attend to. And trust and support is the main thing, and communication should be very clear, and documentation has to be very clear. There are considerable variations in how labor progresses, and it is defined in terms of cervical dilatation and pattern. So it is not that we stick to the original these things that within 6 hours or 4 centimeters she should progress. They are given time, like, every woman behaves differently. So you cannot use a standard. If everything is going on well, we can continue her to progress. So what's normal is a big question. It may be normal for one woman, but it may not be normal for the other woman. So the guiding principles for the WHO intrapartum care model says that labor and childbirth should be individualized and woman-centered. No intervention should be implemented without a clear medical indication. Only interventions like, giving oxytocin, doing ARM, augmentation, only if there's a medical indication it should be done. Induction of labor. Only interventions that serve an immediate purpose and are proven to be beneficial should be promoted, and a clear objective that a positive childbirth experience for the woman, the newborn, and her family. So it is not only the woman, but the newborn and the family. Everybody is involved, should be at the forefront of labor and childcare at all times. So this is how we practiced midwifery in our labor room. As Sheila said, we have brought the alternative birthing positions and methods. So this could be given either in a hospital, or in UK they have birthing centers, or she can deliver at her home with her family members. So this is the interior of our birthing center, which we are conducting deliveries by midwives at Sevagram. So with minimal interventions, home-like settings, licensed, accredited staff's credentials, the delivery experience is certainly much more positive for her. So a midwife is there throughout her for the delivery. In addition to it, the concept of doula is also a part of RMC, where you have trained but paid birth attendants. So right from the time she is antenatal, she chooses a birth attendant who will stay with her throughout her delivery, and she is paid. She may not be a family member, so that is doula. So this we have not yet brought into practice, but gradually I think it may become a part of a childbearing experience. So they are asked to attend the birth center. They are shown the patients, they are oriented, and they are told about the policies. This is something which we are practicing in and out, that is water birth. So labor delivery labor or delivery can both happen in a pool of warm water. It eases pain, speeds up labor, and large expanded room with a view. They feel is not, the acceptance is now increasing, and we have even people who are not very educated opting for it. But whatever experience we have had with our 100 hydrolabors has been very good. There is this concept of hypnobirthing, which is a philosophy. Fear of childbirth incites physical pain. So the mind-body technique replaces fear with relaxation. So if you control the mind, relax her by various non-pharmacological methods, her body will also not experience the pain. So that is hypnobreathing. Then these are the various alternative positions and the way they are prepared before delivery for birth. So this is the all-fours position, the Nietzsche's position, which Madam was talking about, which is found to be very good, and it's one of the favorite positions in which our patients are delivering. And this is the male involvement in birthing, which we have encouraged. so that the male is there to cut the umbilical cord and he's there to support his wife and see how much of pain she's undergoing. Teaching and training has always been a part of this, and active demonstrations of additional techniques to achieve normal birth. So we have Kat here and we have Karen who were actually involved in starting all this. Then this is the birthing chair and Alpha's breathing where the placenta has delivered along with the baby. So no clamping and cutting has been done. This is the indigenous chair which Poonam ma'am got manufactured and which was used for the birthing, chair deliveries, a low cost alternative. Later on, we got the funds so we could have our own sophisticated birthing chair. This again is one of the all-force delivery which is being conducted. So these are the various positions in which the mothers have delivered in our labor room. And you can see that sitting position is one of the favorites. Then we have chair birth, we have squatting positions. This is the massage which is given to the patients by the midwife for non-pharmacological pain relief. All this is actually happening in our labor room. And this is, they see patients right from the antenatal care in the OPD. So antenatal assessment is being done by them. And then once the mother gives birth, she is also happy and the baby is also happy. So confident and competent new midwives are being created in Sevagram and are being sent worldwide. And right now also we have a group which our midwives are training them because now they have become the national medical educators. And not only during delivery, they also follow them up in PNC and give them health education. So these are the dreams with which midwifery was started. And this is what we have achieved. So even the ASHAs have been involved as a part of collaborative care and they are keen to work with us. So the midwifery model of care specializes in respectful care, collaboration, maternal comfort, low medical intervention, and it supports physiological process. Labor or delivery is physiological. We as doctors, when we try to intervene, that is the time when we create problems. If we go for CTG monitoring, if we go for early ARN, if we go for induction of labor, these are the patients you find they'll end up in C-sections. So it is a physiological process. You just have to support it and you'll see more normal deliveries. Establishing MLCU is a key component of the national program. All Lakshya certified facilities also need to have an MLCU. So establishing midwifery services all over India is one of the main aims of the government of India. And this is how the nurse practitioner midwife in MLCU respects your choice of birth companion and birthing position. They support you to choose the birthing position as per your preference, like squatting, hands and knees with a birthing stool, standing upright, resting against a birthing wall, lying on your side. So clinical feedback which we have received since 1.5 years is reduction in episiotomies. However, increase in first and second degree tears, but again that is physiological and that is less painful for a patient rather than a planned episiotomy. And 1, 2, 3 women have been seen in ANC by midwives, 94 referred to doctors if they feel that this is high risk and they cannot handle. So there's an increase in detailed, accurate documentation, good collaborative care, and many supervised birth by learners, and we have many more happy mothers here. So this is the way they document, like every 15 minutes, and then every 5 minutes, and then they sign who has seen the date. I mean, perfect documentation is something even which we have learned. In fact, it has been a very positive experience for our postgraduates because there were certain things which they were doing wrong. But then these people pointed out, and through meetings and collaborations, our postgraduates feel yes, certain things which they tell us are good, and they are changing their practices and becoming more patient and working in collaboration with each other. So there were barriers initially, but we are still working to break down the barriers. And the midwives are helping us in providing antenatal education, fathers' involvement in pregnancy and at the birth, educating women, placing them at the center of their care and discussing choices, developing midwife leaders, and this in turn is helping us in reducing maternal morbidity and mortality, creating a happier and a kinder workplace, and greater retention of midwives brings about a better working environment. So maternal mortality rate dips by 10 points, and Kerala and Maharashtra see the sharpest decline. But there are states where the rate is still very high, and these are the states which have been targeted for improving midwifery care and for reducing preventable deaths in women. And these are some of the feedbacks which we have received from women who have been delivered by midwives, and they've had a wonderful experience. So that's all I would like to talk about. So we just wanted to bring it to people in Varda what we are doing. And if Sneha ma'am is there, probably she would also know what we're doing at Sevagram. So thank you all for listening to this talk, and hope you have a good day. Thank you.
Thank you so much, ma'am, for this informative talk. I request Manisha ma'am or Kiran ma'am to give their expert opinion.
It was a very good talk by madam, and this concept of midwifery is actually very good because they don't intervene the patient, and we as the obstetrician have tendency to intervene. So that because we want that patient to deliver early, so that is very good. Only thing is that this midwife should be trained properly, because what we see in our nurses, they don't have proper knowledge. But if they are trained properly, it will be helpful to us, and this midwifery help will reduce our burden also. So that's all, and it was very good. And I will ask madam that how do you get the response from the patient, madam, when you have started this alternate?
Ma'am, they are very happy. Like when they come, they search for the midwife. The one who was I was showing to, she should only deliver me, because they're giving them one-to-one care. They're very compassionate. And it's a full 1.5 years training program. So these people are actually trained very well. I mean, they can manage things. And anytime they feel something is wrong, the PG doctor is always there, the postgraduate.
Yeah.
So they take their help. Yeah. You
Okay,
had
madam.
a very
Thank
good
you.
experience. Sure, ma'am.
Manisha, you want to tell something?
Yes, ma'am. Thank you, ma'am. It was very wonderful talk. And when we were doing PG at MJMS, we didn't have midwives at that time. So now the PGs are much blessed. I think they are getting midwives, so that monitoring is very nice, and are decreasing the burden of the obstetrician also, and so also the patients are getting a good experience, and they are that key they have having companion with them, and they deliver very nicely in a familiar environment. So it is very nice motive of the MJMS. Thank you, ma'am, so much.
Thank you, Manisha. Thank you, Burka ma'am, for your kind words.
Thank you, madam.
Thank you so much, ma'am. With this, we come an end to our session today. On behalf of DSOGS and Department of OBGYN JNMC, I would like to extend my heartfelt thanks to respected Sneha Bhuyan ma'am and Dr. Suchi Jain ma'am, and esteemed chairpersons, the distinguished panelists and speakers for sparing their valuable time today with their valuable inputs. My sincere thanks to all the participants as well for sparing their valuable time. Hope we have all gained some valuable tips, as I definitely have. Thank you so much, ma'am.
Thank you.
Thank you.